got a nice new shirt on. This is Boyd, your webinar host in the background.
You go to any website, you belong to any other organization or credentialing society, or anything, you're going to hear topics, get emails about telehealth and how are we doing it, how are we billing. So I'm going to break it down a little bit. There is a lot of information, so I'm going to try not to go too fast, but I have a lot of links included. So hopefully you'll be able to grab some of the links and get some information to be able to look up what you need for your particular business. So what is our definition? So telehealth, so CMS, that's who we're going to start with, is Medicare, Medicaid services. Telehealth, telemedicine, and all those related terms, they're referring to an exchange of medical information from one site to another. So it doesn't matter where one person is or another, through electronic communication to improve patients' health. And especially during this time of COVID, that's what we're trying to do. We're trying to not get patients infected while improving their health. So that's the big push for telehealth right now. And I know a lot of businesses, a lot of offices are trying to do this right now. So CMS has this really great booklet about telehealth services. CMS has so much information. It's wonderful. A booklet describing everything that you need for whatever you're looking for. Well, this booklet, they actually just updated. So I've posted this link on here previously for different information we've talked about, or perhaps in a forum. They actually just updated this book in March. So now it is going to read current information due to COVID. And one of the pages is a full page saying COVID-19, this is what we're doing, this is the differences. And they will, once this emergency recedes, they will update their book again to go back to the previous information, which was the traditional telehealth. It had to be an originating site. There are specific sites you had to sign up for, and this is for rural people. Distant areas don't have access to a physician in their area, maybe a specialist of a particular kind. So that's what originally this was dealing with. You had to be established relationship with your provider, but you could go travel to a little further away to get to one of these sites where you could use a camera and equipment to speak to your provider. So you were talking rural areas. Now, because of COVID, CMS has opened it up across the United States. There is no rural definition currently. So I'm going to start with Medicare, because Medicare has put out the most information. Medicare is a large percentage of population of people, and they are the ones most affected by COVID currently. So we want to keep the elderly population safe. So we want to have this available to them. That's the big push by CMS. And we always know other carriers, they kind of come along and follow what Medicare does anyways. So this is what we're going to look at first. Now they're putting all this information out, newsletters, links, the booklet has been updated. They've got so much information. So we're going to break it down a little bit. So they've updated this isn't what it used to be. This is what it is now because of this emergency crisis time that we have. So an originating site can now be an office, hospital, or a critical access hospital, rural health clinics, federally qualified healthcare centers. Now, we usually see those as RHC for a rural health clinic or FQHC for the federally qualified health center. A dialysis center, skilled nursing facilities, community mental health centers, renal dialysis, ESRD from the patient's home. If it's an ESRD patient from their home, and now really, this is an update, this is originating site, or a mobile strike unit. So this is where the physician can be, okay? So the physician, the provider, physical therapist, we're gonna get into that too. So where the practitioner can be is in any of these sites. Now, who can provide this? They've expanded this as well. This is updated. This is not what originally was intended for CMS telehealth, but because of the situation we have, perhaps in your area as well, they are asking for all retired doctors, retired nurses, old Army people, corpsmen. They're recruiting as many people as they can to come help relieve some of these providers who are becoming quite stressed in this situation. And they need people. Perhaps you're creating some kind of field hospitals or these drive-through tents. They need more providers. So they've updated all of these providers: physicians, nurse practitioners, physician assistants, nurse midwives, all sorts. And then even our clinical social workers, registered dietitians. So these are additional distant site providers who can provide telehealth services. Now, what services can be provided? Professional services. We are talking doctors here. We're not talking in a hospital because there's other codes involved with that. So a professional medical provider, okay? So I know we said they can be in a hospital, but that's the professional component, not the facility component. That's totally different. So evaluation and management services, mental health, preventive health screenings, they still need these things to be done, but we don't want them coming into an office full of people where they could possibly be infected. And this is now any diagnosis. This is for CMS. This is Medicare. They're opening it up to any reason, not just COVID. You have somebody who has to follow up for hypertension. You have somebody who has to follow up for a rash, diabetes. The one thing that, of course, say you are a specialist and you perform surgery, if you're in that global package, it still falls under those rules. If it's a post-op, you can perform it, but we're not billing for it because it's post-op. So it's what normally takes place in an office, we're now able to do via telehealth. Normally, if they came into the office and they're in a post-operative period, we didn't bill for it. It's going to be the same thing here, okay? What does it require? What do we have to have? Originally, you had to be a site that had cameras and all sorts of equipment to be able to use. This is an interactive audio and video telecommunication system. Whenever you pull up any picture of telehealth, it's going to show somebody on their tablet or their phone talking to a doctor. You have to have that video for telehealth. Okay, there's other codes we can use, but for telehealth, we're talking audio and video. Real-time communications, not this leaving a message, getting back to them, or sending a picture and then you send something back. This is real time. So it's all happening at once. And the originating site must be a physician's office or other authorized healthcare facility that we mentioned on that list just a little while ago. And then the beneficiary can be in their home or another setting. Okay, so the beneficiary can be home. Now, I have seen some sites, I did a lot of research on this to try and get the most up-to-date and accurate information available. I had seen that somebody said, well, the physician can be at home. What if they close your office? The physician can be at home, but now he has to change his address. So whatever he's billing from, he has to change that with Medicare. So, I don't know that for sure. I didn't see that anywhere except one person's question. So that I'm not entirely sure of, but I know that there are different situations going on across the US right now that is possible. And if that is something that may need to be done, I would reach out to CMS and ask them. They're the experts. They're the ones who know this information, and they'll be able to answer that question if that's the situation that your office is in. This is just a quick little snippet that I took out of this booklet because it's 4 pages long of all the codes that can be used in telehealth. And this has been the updated version for March. So these all sorts of codes, behavioral health codes, renal dialysis codes with exceptions that are noted in there, office visits, all different kinds of codes that are out there. So definitely, if you're in a particular field, a particular specialty that maybe I'm not going to cover, check it out. Pull up this book and just Google CMS telehealth. It will come up with this booklet for you. That easy. They make it really easy. So how do we bill this? This is what you guys want to know, right? So for Medicare, you're submitting that CPT or a HCPCS code. Because remember, if a HCPCS is more definitive, we're using the HCPCS codes for Medicare. If it's performed through asynchronous, that means not at the same time. Asynchronous, not synchronous. So, and those take place, those are particular areas in Alaska and Hawaii. So unless you're in Alaska and Hawaii, that line isn't going to refer to you, but we have people from all across the United States who may need to know this information. So if it's asynchronous, you use GQ modifier, and that lets them know it's asynchronous. Your place of service is O2 for telehealth. Okay, this is what we're talking about right now is telehealth, this whole list of all these different codes that you can bill. If you are a critical access hospital under a payment method 2, then your institutional claims, you use a GT modifier. So that's information included in this booklet. So you'll be able to look this up if you're a critical access hospital. If you're a facility, remember I talked about what about the facility side? That's a different code. So this is professional services we're talking about here. The doctors, the nurse practitioners, professional services, their component of this. Again, this newsroom fact sheet, this describes this so well. I have the link here, and at the very end, I have another section of all the links that I've used. So Medicare telehealth visits. These are office, hospital visits, clinic, any type of in-person services that you'd normally do in person, right? An interactive audio-video telecommunication system with real-time communication. So it has to be that exchange of questions, real-time. You two can see each other. This communication back and forth. Effective March 6th. There is no end date currently. Medicare says through the end of the COVID emergency. They haven't labeled, it's not, now you'll see a lot of the insurance carriers, they're going to give you a date when it's effective through. CMS has not, okay? Through the end of whenever they're going to declare this emergency over. Any visits billed via telehealth are going to be paid the same as if you were in person. That's great for our providers. Keeps the reimbursement flow going for business because we already know so many businesses are closed right now, and that's a problem. Payment for the professional services furnished to beneficiaries in all areas of the country, in all settings, in any healthcare facility, and in the patient's home. So we're talking no exceptions here. The providers may reduce or waive that cost share, the deductible, the 20%, whatever the coinsurance that may stem from a telehealth visit. It's up to the provider. If they want to offer that benefit to the patient, Medicare is still going to process it the same way they would if they were seen in the office, which means it could go to their deductible or they could be responsible for 20%. It's up to the provider to say, okay, during this time, we just need to get these patients taken care of. We want to make sure that they're healthy. We will waive their portion. Whatever they want to do, it's going to be up to the providers. And during this time, CMS and OCR will not be conducting audits to make sure that you have a previous relationship with that patient. Because typically, this is for established patients. That's what telehealth is for. So during this time, they're not going to perform an audit saying, well, that was a new patient. You can't do that via telehealth. They understand the state of emergency. So they're going to waive that. During this time, they're not going to perform an audit. Everything still has to follow medical necessity. Everything still has to be properly documented. We're never going to get rid of that. But during this time, they're going to say, okay, you've never seen that patient before, or you know them, but it's been 4 years or 5 years since you've seen them, which now makes them a new patient. 3 years and 1 day now makes them considered a new patient. You may have a previous establishment with them, but they're considered a new patient at this point in time. So this is not an inclusive list. Like I said, there were 4 pages in there. So just a lot of different codes that are available. We can see office visits, advanced care planning, psychiatric, a lot of behavioral health. During this time, people are undergoing a lot of stress, a lot of anxiety. They've lost their job, their kids are home all day. What are we going to do? You know, I can't afford some of these things. I know a lot of states are coming out with, you know, unemployment, immediate unemployment benefits, which is really nice. But they're still going to be stressed because unemployment's not 100%. So they're still going to be stressed. So a lot of these codes are for behavioral, and you'll see a lot of insurances are offering behavioral telehealth services as well. Another service that Medicare describes is virtual check-in. Now, this is described as a brief communication with practitioners, not your med tech, not your RN, unless they're qualified in your state to provide services. But these are practitioners via that technology of synchronous discussion back and forth. We need that back and forth banter and conversation over a telephone or exchange of information through a video or image. So you can use your telephone services here, but look at this next bolded big part, initiated by the patient. This is not the doctor's office calling every patient, hi, would you like us to check in on you? Okay, how are you doing? Blah, blah, blah. Okay, I'm going to bill for this. No, this is initiated by the patient. Now you can contact your patients, send out an email blast, patient portal message, text message, however you communicate with your patients, letting them know you offer telehealth services. You can let them know that these services are available. That way it's up to them to say, you know what, I really don't want to come into the office. I'm really not comfortable with that. Can you treat me? And they will initiate the conversation then. But in this case, it must be an established patient. You cannot do a virtual check-in on a new patient. These must be established patients via Medicare. Okay, this is Medicare's rule. So you cannot have a visit within the previous 7 days with these people, and they will not be following up in the next 24 hours or as soonest available. It's Thursday and your next opening is not till Monday. That's your soonest available. So it's over 24 hours, but because there's a weekend there. So we need to make sure that we are following the rules that are set forth in CPT. And this is one of these rules. The patient consent is required every single time. You can do 4 of these in the next 4, 5, 6 weeks that we're going to be under this COVID emergency. But every single time, you have to get the patient's approval, and it has to be noted in their medical record. All right? Very, very important that this is what Medicare says as their rule, so it's very important to follow it. And the same documentation requirements as an office visit, that's what you should keep in mind anyways, is that we need to prove the medical necessity of all these visits. How are we going to do that if we don't document the information? So we need to prove that. We need to say what the conversation was about, what the outcome was, what's going to happen, okay? A virtual check-in, these are your codes we're going to use, G2012 or G2010. So G2012, and this is what Medicare has written down, telephone communications allowed per their CMS newsletter. They will allow these telephone conversations, audio, video. It also says in their newsletter, secure text messaging, email, or use of a patient portal, 5 to 10 minutes. Now, this should be documented. 5 minutes of conversation about this, okay? 8 minutes of conversation about this. 15 minutes of conversation. Doesn't mean it can't be only 5 to 10. CMS says audio only real-time telephone interactions in addition to synchronous two-way audio interactions enhanced with video or other kinds of data transmission. That's their definition specifically. I pulled it straight from CMS, okay? The OCR is relaxing that HIPAA requirement right now. That FaceTime, Skype, Google, whatever kind of services are out there, not Snapchat, not any of those funky apps. These are a video, something like Snapchat or TikTok, those are brief. So the video services are brief. So this is FaceTime, Skype, something that has an interaction. But what happens when you're on FaceTime or Skype? You might have people in the background, you might have other things going on. That's why HIPAA is important. So, and there's always not a secure communication. That was the original intent with telehealth and those originating sites, is because it's secure. That, we've met all those requirements of HIPAA. HIPAA is not just patient health information. So there's a lot more to it with other security measures in place under HIPAA. So as long as your services are in good faith, they are relaxing their HIPAA requirement, okay? But let's not abuse it, because then we're outside of good faith. So a G2010 is you're using video and images sent to the physician. So we can use both of these codes, or we can use these codes. I don't mean to imply you can use them both together. We can use these codes if our services fit the description described by CMS. I still have not recovered from my flu. E-visits. E-visit is non-face-to-face. You don't have that communication. You don't have that video. Of an established patient, again, established, not new, established. And again, patient-initiated communications through, most of us all have online portals. It's actually a requirement with CMS for some of our MIPS and other things we're supposed to have available for our patients for communication and good patient care. So patient-initiated, established, non-face-to-face communications, they can occur over a 7-day period. Send a message through the portal, answer through the portal. Send a message through the portal, answer through the portal. It can be this back and forth dialogue, which needs to be documented. And the patient consent needs to be documented as well. The patient is consenting to the, do you know why the patient needs to consent? They're still responsible for a portion. So the patient needs to be aware that they only telehealth the physician could waive. These e-visits and virtual check-ins, the patients are still responsible for that 20%. So they need to be aware. They may be upset that they're getting a $4 bill in the mail or something. So we need to make them aware that they're still responsible for their portion. Now with e-visits, physicians and nurse practitioners who are able to bill an E&M, if they normally bill those services themselves, not incident to, if they normally bill those services themselves to CMS, they are eligible to use 99421 through 99423, that family of codes. It's time-based, so depends on how long, for an online digital E&M service for an established patient Cumulative time over 7 days, okay? Clinicians who may not independently bill an E&M currently, occupational therapists, physical therapists, clinical psychologists, they are going to use the HCPCS code G2061 through G2063. That means a qualified non-physician healthcare professional doing an online assessment. The same thing, time-based, accumulation over 7 days, communication through these portals. That's an e-visit. Now, place of service, everybody's confused about place of service. Telehealth for Medicare is an O2 place of service. Virtual check-ins and e-visits, if the doctor was in the office when they're performing this, then you use an 11. You're using the place of service where the provider was. So in my example here, the provider's in the office doing these virtual check-ins, billing an 11. Modifiers. There's nothing different we need to do. The same old traditional modifiers we would normally do with these services. If you're in Alaska or Hawaii doing asynchronous, GQ. If you're billing under the critical access hospital, GT. If you're doing a diagnosis or a treatment of an acute stroke, GO. So, and these actually, some of these came from samples. The AMA just put out a whole bunch of scenarios, which are wonderful. So there's a link there. It is also posted in our club, a link to these. So that's where some of these came from, to know the place of service and such, okay? Commercial insurances, Medicare, we're done with, okay? Commercial insurance, United Healthcare. As of today, so I just pulled this off today, they are saying from today through June 18th, so June 18th is their deadline. Medicare was whenever this emergency ends. We don't know when it's going to be. United Healthcare says June 18th, and who knows? These dates may be revised, so keep up with their websites. If these are carriers you use, check it out. They'll probably send you communications as well, as long as you belong to their listservs, but just make sure you keep track of these. So currently it's through June 18th. All commercial and Medicaid plans, they're waiving that originating site requirement, allowing for home or other location of their members. So they can bill for telehealth if the patient's at home or someplace else. They're waiving that right now. They used to have a policy in place that you couldn't do that, but again, we're waiving it. They will reimburse telehealth services recognized by CMS with modifiers GT and GQ. So we just went over those, the ones in asynchronous or the critical access hospital, or services recognized by the AMA CPT codes with a modifier 95. So United Healthcare is asking for the 95 modifier with any of those services, or if you meet some of the other requirements with CMS. Through June 18th, Medicare Advantage plans through United Healthcare. So United Healthcare's Medicare Advantage plan. They're waiving the originating site requirements, allowing home or other location, same as the commercial Medicaid. They will reimburse codes with payable under Medicare with the O2 place of service and GQ or GT modifier dependent upon the circumstance, okay? So this is what United Healthcare said as of today. They say their definition is care providers may conduct a telehealth visit from any private, secure location that will support member privacy. How do you interpret that? Physician's home? I don't know. But it says, this is why it's in quotes, this is directly off their website, any private secure location. I don't know. So use your best judgment. confer with your providers. What do they want to do? If you're in the case where your business is shut down and the provider is working from home, contact United Healthcare. Ask them specifically that question, okay? That's a vague answer that they gave there. The referral requirements for specialists must still be met. So if you're a cardiologist, you still have to have a referral on hand to do telehealth services. They will do the virtual check-in codes. So we went over those under CMS. E-visits, they will extend to the United Healthcare Medicaid plans. So if you are a participating provider with any of the United Healthcare, Medicaid, used to be AmeriChoice, plans until June 18th. So again, that date of June 18th, you can do e-visits for Medicaid plans. E-visits or audio-only telephone codes are reimbursed with those codes. That's what United Healthcare is using for e-visits or telephone calls. So there's always been a lot of question. Well, Medicare doesn't take this code, but maybe a commercial would. They're telling you what codes they're going to take. Okay, so very good information here for United Healthcare. How do we bill it? United Healthcare requires one of those modifiers. They recognize the O2, but they don't require place service O2. This is on their website. This is actually off of one of their telehealth brochures. It's linked at the bottom there. That was just updated March 6th. So this is what they said. They recognize it, but you don't have to submit place of service O2. If you're sending one of those codes and it happened in the office, you're going to send place of service 11, okay? They do not allow. So don't try and bill one of these other codes. The T, telehealth transmission code, they don't pay for it. The telephone services codes that are listed in the CPT manual or those online medical evaluation codes, they're not paying those. So they already told us what codes they're going to pay. So as long as the services you're rendering meet the criteria of those codes, that's what you can bill. So look into those and see if your provider can bill those codes. Aetna. Now I'm doing just some of the major carriers here. Blue Cross Blue Shield, unfortunately, every state is different. So please pull up your Blue Cross Blue Shield for your state. If you need to, in the search box, put COVID-19, put telehealth, telemedicine, you're gonna get something. If it's not right on their front website with a link, they will have something. You will be able to find it. It was easy to find these through these websites. Aetna, theirs is through June 4th. So they're 2 weeks different. So write these down somewhere, keep track of them, because everybody's going to have a different date. Unfortunately, nobody has one clear set date, or all of them don't have one clear set date, which is unfortunate. So they're going to waive the cost sharing for any diagnosis through their telehealth, which is called TeleDoc, or an in-network provider. In-network provider. So if you're not part of the network, but the patient has that choice POS where they can go somewhere, you're not in network, okay? So they might have a benefit to go out of network, but you're not in network. So the patient is still going to be responsible for something then. We need to make our patients aware of this, because everybody's hearing right now, COVID's free. If it's related to COVID, it's free. Well, those are the tests. Those are, certain things. And those could be from your state governor that's saying that, not your insurance carrier. Waive the cost sharing for any diagnosis. So they fortunately opened it up. Most of these, I think just when we did this last week, a lot of them were for only COVID. So they've opened it up for any diagnosis. They will use the G 2061 through 2063 online assessment. Those are time-based, so it depends on the time increment you use as to which code from that family you're going to bill. Those are the qualified non-physician online assessments. They also do 98970 through 98972 for the online digital E&M service. The 99421 through 423 online digital EM service for a physician or a provider. G2010 and G2012. We've been over some of those. The 98966 through 98968 telephone assessment, which is time-based. And they also do the 99441 through 99443 telephone E&M. Not many carriers do those, but Aetna's one of them that will be doing that through June 4th. There are numerous psychological and behavioral codes. There were a lot listed on their website. If you are in behavioral health or performing behavioral health, please pull up the website. Here's the link and find out which codes you can bill, okay? Because there's family, there's individual, there's, just in relation to so many different types of things when we talk about behavioral health. So how do we bill Aetna? So they define telemedicine as two-way real-time audio-visual interactive audio-visual communication. So that was just from January 1st when they updated their telehealth manual. So we need to keep that in mind, that telemedicine is that audio-visual two-way. So telemedicine, they use the O2. As of March 6th, they're asking that claims should be billed with one of the following modifiers, either GT or 95. So it depends on the code you're billing, because HCPCS, we'd use a HCPCS modifier, CPT, we use a CPT modifier. So they should be billed with one of those modifiers. Now remember, some of these dates can be retroactive too. So, it's March 26th, but if you had a code from a couple weeks ago that you need to send in because you've been waiting, wondering how to bill it. So as of March 6th, they will use those codes. Cigna. Now Cigna's May 31st. So again, we got a lot of different dates here, okay? That virtual care not related to COVID by physicians or certain providers with virtual capabilities. So they're saying that you can do virtual care. It doesn't have to be COVID related. Physicians and certain providers with virtual capabilities. In relation to COVID, they're waiving all the costs to the patient. So if it is COVID related, use those COVID ICD-10 codes that have come out. If you don't have those are also on the CCO Club. You can see them in the forum. A whole nice list of all this information is all located there. The virtual care not related is by a physician or certain providers. So we need to make sure that we're looking at the CPT codes and what are Cigna's requirements and billing them properly. So the providers can bill a standard face-to-face. So how you would normally bill it face-to-face for all your virtual services. So this is what their website said. So a standard face-to-face for all virtual care services. So how you'd bill it if they're in person, that's how we're billing it for their telehealth or their virtual care is what they're referring to it as. So through May 31st, so how you would bill it in the office, that's how we're billing it. Use face-to-face E&M codes with the GQ modifier. So see, they're totally different than everybody else, and they're asking for a HCPCS modifier with a face-to-face E&M code. So everybody's doing something different. So definitely double check, make a spreadsheet, make a cheat sheet to be able to make sure that we get all of these listed properly with the proper carriers, especially with those through dates, because after that date, they may not accept these anymore. So definitely double check and make sure that their site hasn't been updated in the meantime. And the typical place of service that you would have billed for that face-to-face code. So that's what they're asking for. They're not asking for an O2. You're going to identify that you did this virtual by saying that GQ modifier. That's how they're going to know. So it's face-to-face with the GQ, place of service 11, 21, wherever you did that place of service for that E&M code. They are allowing the G2012 for a 5 to 10 minute phone conversation, and they will waive the cost share for the patients. Remember, you're still following those rules. Those are established patients, patient initiated. Okay, that still goes for those G codes. And their system is going to update on April 6th. So if you build any of this today, they may not understand it. Their system's going to update on April 6th, but it's going to be from data service 3.2 through May 31st. So they're pretty much covering all of March, all of April, and all of May. So if you provided any of these services in those 3 months, we'll be able to bill them effective April 6th. They will update their system at Cigna to accept these codes with the GQ modifier, or whichever the codes you're billing for. And again, there's their website there at the bottom. So through May 31st, they also said for virtual physical therapy, occupational therapy, or speech services, they're allowing those to be done virtually for those CPT codes listed. So you can do those virtually with those codes. Again, they're asking for the GQ modifier, the standard place of service you would normally bill for your services. And again, they're going to update their codes April 6th, but it could be effective from any date from March 2nd through May 31st. So those 90 days, they're allowing virtual physical therapy, occupational therapy, or speech codes to be billed. Medicaid, this varies by state. Each state is different because currently each state kind of has given their own rules as well. So most states are waiving COVID expenses for tests and things like that, but it depends. Every state's different. So what your state Medicaid system is going to do is going to be different. So definitely pull up your state's medical assistance plan. Search COVID-19. If it's not the first thing that comes up, I bet it is. It'll be right on their website. And then the eligible dates may also vary. So like we saw with all the other carriers, we had June, we had beginning of June, and then we had May. So it just depends. So your medical assistance plan may do the same thing. Your state may have said until the emergency ends or through a particular date. So they just double check with your state. And also because not every state uses the same codes. Some might use HCPCS, some might use CPT. So we need to know what your state does for telehealth. So example, I pulled up my state. I pulled up Maryland. So they are requiring a GT modifier with an E&M code and the place of service appropriate for that non-telehealth claim. Where would you normally have done that? They don't recognize O2. They won't even process the claim. My state, they send it back to you, and it's not a quick process. So we need to make sure you look up your state. And theirs was effective March 2020. Any place of service is allowed until the emergency is lifted. So that's what our governor implied, that we can do telehealth at any place of service for the state Medicaid until he lifts the emergency. We don't know when that's going to be. CMS did also have a little bit of information because CMS is the Centers for Medicare and Medicaid Services. So they had just some brief information. It is not specific to any state whatsoever. So I would definitely go to your state Medicaid plan and see what they are going to allow. TRICARE. I actually just received this today in a newsletter from TRICARE because that's my insurance. So provider needs to offer telemedicine services for office visits, preventive health screenings, and then telemental health services. You still have to follow those referrals. So if you have TRICARE Prime, They still have to require a referral, even for telehealth if you're a specialist. Telemedicine, they will not do audio-only conferencing, phone calls, or any kind of text. So some of those other services we saw Medicare paying for, TRICARE is not going to pay for. Billing them, they use the GT modifier for your synchronous services and the place of service 02. So everybody's been different that we see. So it's really important to look at these websites and know what they're offering or what they require. I'm sure there's going to be a lot of trial and error. There's going to be, if it didn't go through the first time, they didn't like it, try 11, try 02. It is going to be trial and error, and it's also trial and error on their end too. They have to set up a policy now going, okay, they've got to revamp their computer systems. They've got to redo everything to say, accept this code during this time frame with this diagnosis or whatever the case may be. They want the GQ modifier for asynchronous services, and the patient signature field, they wanted to say signature not required distance telemedicine site. We haven't seen anybody else say that, so everybody's different. So again, make that spreadsheet, pull it up and then print it off and put it on everybody's above their display monitor. If they're all working remotely, send an email to everybody asking them to print it off or keep this up on their screen, or bookmark it so they can pull it up whenever it's needed. So there actually are two different websites there. The bottom one is their manual for telehealth, so it's kind of big, and the other one is just they have very brief information, but that's a link to Humana Military for TRICARE for what they are doing during COVID. But then the other one is their telehealth manual. Behavioral health, I didn't touch on that a lot because there are a lot of codes. So it's a lot of information for behavioral health. And again, we're not just talking licensed social workers here. A lot of different, it's been opened up to a lot of different providers because they are seeing an influx of need for behavioral health during this time, especially telemedicine just makes it convenient to handle a lot of these people during this time. So a lot of concerns, there's a lot of paranoia, there's a lot of anxiety going on, stress, again, like we said, people losing their jobs or, just not sure what to do. Everything's closed. How do I handle everything? So definitely look up all the insurance carriers. Now this site I included, this is a biller for behavioral health. This is her profession, and she had a really nice breakdown of a lot of the insurances behavioral health. So if you're in behavioral health, check out that website because she's already done a lot of the work for Cigna, Aetna, Blues, just a lot of different carriers out there in behavioral health. So really good website. And if you have any other behavioral health questions, she has a good blog too. A lot of good information there. Now these are all of the links that I used. So there are some additional links at the bottom. CMS has their telemedicine toolkit. So that was a nice reference as well, knowing what to bill, how to bill, when to bill. HHS, their HIPAA. How are we going to be prepared for HIPAA? What is involved in HIPAA right now? NAMAS had some good information. So they're an auditing society. So if you curious about documentation, how things are labeled, that's a good site for those, as well as the AHIMA telemedicine toolkit is another good site that listed, you're supposed to include where the patient was, where the provider was, that you have the patient's consent to perform these services. So all should be documented in the record. So some of the documentation is included in that telemedicine toolkit. So I am going to see currently if we have some questions that I can possibly go through. because that was the last one we had. Now, I did see somebody, and okay, so somebody asked a question about annual wellness visits during this, and I do believe that Medicare did touch on annual wellness visits, and I apologize, I cannot pull that off the top of my head because I've looked at so many sites, and I think in the past week I've gotten probably 50 emails from compliance agencies and NAMIS and AAPC and AMA, AMA, and I've gotten so many emails. I know I've seen it and I know it's out there. We can probably put something in the forum or, and I can look directly into that. But I know I've seen something about annual wellness visits during this time. I just cannot pull it up off the top of my head, and I apologize. And the FQHC and RHC's funding for telehealth. I have not seen anything for the funding. I don't know if that's included in that package that was just passed, but that was a lot of information in that package that they put, the stimulus package. So they have not said directly about the funding, but they did say that those sites can be used for telehealth. So but I don't have the funding portion. That would be something to look into, I'm sure. CMS is putting out stuff almost daily. So if you're not on their listserv, I would apply for their listserv. And you can do specifically for areas that you want to receive information on as well for cms.gov. And then also check with if I'm not sure off the top of my head if they fall under a particular MAC carrier or not. As to whether that would cover, if a particular MAC carrier would cover. Somebody wanted to know if we can bill the G2010 for interpretation of a patient self-administered lab, like a urine dip analysis. That's a very interesting question because G2010 is for images. But I'm but where the 81002 comes into play is your materials, your time. So if this is all patient administered, I think the only thing that would work is one of the other codes to discuss the medical necessity, the outcome, the medical decision-making process of that urine dip analysis. I don't think the 81002 can be billed. I mean, the interpretation is going to come into your medical decision-making process, if that makes sense. We can't do 81002 because it's not your materials, it's not your equipment, you didn't perform it. So can we bill for all insurances in all states? Well, I'm kind of curious about the question because all insurances, we can bill to any insurance in any state, yes. But if, say, it's Blue Cross Blue Shield of Arkansas, I'm in Maryland, I'm going to bill through Blue Cross Blue Shield of Maryland, and they will contact Blue Cross Blue Shield of Arkansas. Cigna, we file to a Cigna carrier with a particular address for our geographical region. TRICARE is divided by East and West. You have to bill specifically to your carrier. You can bill to, you can bill to West. If they have TRICARE West and I'm in TRICARE East, I bill to TRICARE West. They may not pay it, or it goes through a different process is what it is, because TRICARE Overseas is the other TRICARE carrier. So most, Medicare, you're going to bill to your local MAC carrier. The patient could be from Montana and have Medicare coverage, but I'm going to bill to my local MAC carrier. I'm not going to bill to Medicare of Montana. Something like a medical assistance, no, because you have to be a provider, and it has to be your state, and it's only good in your state because you're a provider only in your state. And it goes the same for the managed care plans, medical assistance managed care plans. And if anybody has a Medicare Advantage plan that's possibly an HMO, like we used to every once in a while get a patient with a Florida Medicare HMO plan, they're not able to seek care in Maryland. They need authorization and things like that too. So it depends. An HMO plan would be different, but most carriers are nationwide. You just may have to file to a particular carrier in your state, possibly. Hopefully that answered your question. You see patients in skilled nursing and you complete an initial H&P. They're trying to determine if this H&P can be done via telehealth. I would go back and read that brochure because skilled nursing, I assume you're billing Medicare. So I'd look at what CMS says. You can use a skilled nursing facility, but I believe their codes are specifically for subsequent care, not initial. So for office visits, they are not going to audit a new patient code during this time. But I believe in what I read, nursing facilities, skilled nursing care is subsequent visits only. So they wouldn't be able to do the initial via telehealth. Do I know if CMS is allowing telehealth or virtual check-ins with family members when the patient does not have access to virtual technology? There's nothing said about that specifically, but I can see the scenario. I mean, we don't want the family member going to the patient, but I think in that case, you're going to have to bring your computer or your phone to them so they can use it. I know that doesn't really seem to work well, like, because if they're in a nursing facility or some kind of adult care home, they may not be letting any visitors in, but hopefully a nurse in that building, if that's the case, somebody working in the office or, you know, somebody is going to have access to something that that patient can use to speak with the doctor. It didn't say specifically about family members. So that's a rather interesting question, but I haven't found any information speaking to that in a particular scenario. Any updates on whether or not CMS will be waiving patient co-fees? No, they are not. The only things that they are granting is the physician to make that decision whether they want to collect that from the patient. They are not mentioning anything about waiving it like other insurance plans are, but remember, those other insurance plans are commercial. This is Medicare, it's a federal plan. So they have not said anything about waiving. Only the physician may decide on a telehealth visit if they want to waive those deductibles or fees. Are physical therapists allowed to bill from their home, or must it be in an office setting? Whatever I came through that I found said the traditional setting. Now, the same instance where some of these offices are being shut down, I would contact that carrier and ask them if they allow it from home. Most of them said you're billing under the traditional setting, and that, like I said, the one article I saw said that you'd have to change your place of service, then your address for the place of service when you're billing these services. So that's definitely a question for the carrier, because as you could see, everybody had something different in place. They all had different rules. So, one of them was vague as to whether you could do that from home. So it would be up to the carriers themselves. I didn't see anything specifically about that though. Is there any information on just telephone calls from provider to patient? Now remember, telephone calls need to be initiated by the patient. Now in that AMA, one of these links here, the AMA, that third one there, the COVID coding advice, they did have a scenario in there about phone calls. And I know, I can't remember off the top of my head, one of these other ones specifically said, like if we called the patient to confirm their appointment, what is that? Or, how are you talking to the patient about their appointment? And they brought that scenario further. But remember, it was patient initiated, and it depended upon the insurance carrier because all of them were different. So can you bill a secondary if they have one? If you are participating with that insurance plan, then yes, you bill the secondary. Now the secondary may not, like we said, okay, what if their secondary was Cigna and the primary was United Healthcare? Well, they had different dates. So that's just going to kind of depend on how they're going to process the secondary, because CMS had their rules and you saw the other plans had different rules. So what if they had Medicare primary and Cigna secondary or Aetna secondary? So they're just all going to kind of have their own plans and their own rules, and it's going to be kind of up to a decision between the patient and the office as to what they want to do if they're outside of that time frame. So CMS, Medicare, they said, oh, well, we're still under the emergency quota, but the other one expired May 31st. So it is a really tricky, tough situation when you're dealing with secondaries. So I'm not sure, but if you have a secondary, still bill it, because it could be beneficial to the patient that they may not pay as much, or they may not be responsible for as much. It can be a new patient. So somebody wanted to know, if it can't be a new patient, why are the codes on the list? For an office visit, 99201, 202, 203, 204. I think they specifically ruled out 205 because you can't meet a 205 virtually. But you can do those codes. They're allowing it during this time only because of the state of emergency, because of the problems that it's causing. They are allowing it, but remember, we got to try and meet those criteria described in CPT. So they can still assess some of an examination, alert and oriented. You can still get psychological, or to the best of their ability is what they're looking for, and always in good faith. So whatever's documented to the best of their ability that they can achieve for a new patient during this time. So it's all going to go by medical necessity as well. Can we go by time? That is a tough question. I have not seen that directed anywhere. Time is tricky anyways, especially from an auditing standpoint, billing standpoint, CPT. Time, I know time will be in use next year in 2021. Time has always been tricky. I have not seen anything specifically set out by CMS when they listed those CPT codes saying you can use time. If that is what your office typically does, or you establish a policy to bill upon time, then I can't give you a definite answer. That might be a good question to ask your area representative for Medicare. ask the MAC carrier. Definitely look up the MAC for your area. They should also have information for COVID and see what they normally do. And if they normally allow time as a general policy, then I'm not sure if it's being relaxed during this time or not. I'm going to try and just there are a whole lot of questions, and I apologize. I'm not going to get to them all. I don't know how long we're going to, we want to keep running. Documentation. Okay. I'll try and get to as many as we can, but without, boring everybody. I'll try and get through them. Yeah, there are quite, I think I'm not even halfway through right now. Yes. What are the documentation requirements? Typically, for the telemedicine, anything you would usually document. For the e-visits and the virtual check-ins, they want to make sure that consent is there, and you need to prove the medical necessity for billing. You can't just say I had a 5-minute phone call with a patient about a rash on her nose. It needs to be, what's your medical decision-making process? What other signs and symptoms were there? What's the area of concern? And what was the outcome? Did you tell them it will be fine, put some hydrocortisone cream on it? Or, this should all be documented. So any other documenting standards you would normally use, granted, you may not be able to use your template in your EHR. Maybe they have to dictate this or transcribe it or something. But as much as you can dictate, again, that consent is very important. And that AHIMA tool kit describes what should be documented as well. What if during that 7-day period the patient calls for a different symptom? Can you still bill, or does the rule of 7 days apply no matter if it's related or not? Now, the reason they went with the 7-day rule is because originally, before they allowed these codes to be billed in 2019, anytime patients used to call us before, and we just couldn't bill for it, right? So anytime that they had information and they called and we said, okay, come in 3 days or come in at your next appointment, we used that telephone call, which was documented in their record, as part of the assessment in the next visit. We just never got paid for it. So now they're allowing us to get paid for it. So as long as the codes are meeting the guidelines, there is no limit to how many of these phone calls you can do or how many of these virtual codes you can do. The limit was on the e-visits, 7 days of continual conversation. So if it's falling into that e-visit and you're doing it through the online portals, then if it's a different problem, then you're showing a medical necessity of something different, right? So you can still bill those codes. If they were seen 8 days ago, now on day 8, they're calling for something else and they're not coming in and following up, we're billing for that one under one of the allowed, perhaps telephone codes, G2012, whichever code fits the scenario. So remember, we're going by documentation here. So if they can prove it and it holds up, meeting medical necessity and all the documentation guidelines, then we should be able to bill it. Somebody had a question, I believe, regarding physical therapy, telehealth. There were only a couple carriers allowing physical therapy, and Medicare did include information about physical therapy in their telehealth booklet as well. So if physical therapy is your field, then definitely look into what they said in the CMS telehealth book, or the particular carrier if it's not Medicare. Place of service for virtual check-in, is it an 02 or a 12? As we saw, it depends on the carrier. Some are recognizing 02, but like when you do a durable medical equipment, you bill that as a 12 because that's where the patient is. Nobody mentioned 12 for home. So you're either doing 11 or the facility you're in, whatever place of service you would normally bill for, that code of the facility you're in, or 02. So they were dependent upon the carrier. That's why I tried to give as much information about modifiers, codes, and place of services as possible that I could find for you. A lot of older patients do not have a video capability, just telephone. So which codes do you use for Medicare visits for telephone only? That's going to be your G2012. That was described by a telephone communication, not necessarily audio video. Medicare CMS specifically said telephone in their description that they gave for the G2012. That must be established. They do not allow new patients for that one, and it has to be patient consent documented. So it has to be patient initiated as well. So you can let the patients know, send them a letter, call them, and let them know you offer telehealth. If that's something they need, hey, give us a call if you're having a problem. Now they're calling you and they're initiating a phone call. Do we tell the patients that the service will be billed? Yes. What's the best way to approach this? Is possibly, like I said, if you can put out a blast through your patient portal, messages, a letter. Somebody in your office might want a job of stuffing envelopes. Anything that is a way to communicate to your patients you are offering telehealth services, and check your carrier's guidelines as to what services are paid, or what your patient responsibility may be. Now, if they call and say, oh, I got this letter that you're doing telehealth, I don't have to pay for that, right? Because I heard on the TV everything is paid for right now. Well, no, give them a little bit of information that no, that was only your COVID tests or whatever your state might have said, or or if they're going by what the federal government is saying, clarify that for them and let them know your carrier may still allow a patient responsibility for this service. So you don't have to know exactly what their insurance company is going to say, well, we're going to do a $25 copay, or no, it's COVID related, so we're not paying anything. We don't know that. So we need to say, and you could have Blue Cross Blue Shield of Maryland. Well, there's 50 different plans of Blue Cross. I don't know which one pays for what. Each one's might be self-employed. It could be through a carrier that pays for everything. There's so many plans out there. We can't know every single one of them, but your insurance will cover this. You may still have a patient responsibility. And if they're okay with that, then then we're good. And if you think about it, these patients, if you let them know this is good for you, good for, we don't want to spread anything, we don't want to put you at risk. We can offer this service, but you may still have to pay a portion. I don't think too many people would complain. They might complain if you didn't tell them and they got a bill. So many people are very understanding right now. So that's just kind of the world we live in, unfortunately. What about Modifier 95? So like we saw, some carriers wanted 95, some wanted the GT. It did depend on the insurance company, unfortunately. So hopefully the information provided, which most of it I found on those carriers' websites. So if you didn't have access to this, go to that carrier and pull it up. It was not hard to find. Compiling all this information did take a couple hours, but it's a lot of information. If you're only looking for one carrier, it's not going to take you that long to find it on their website, if you can't remember what we said today. Can residents see patients with the doctor with linking language modifier GC? It was specifically for providers. Now, I did see something on LinkedIn today, an article about how they are now using residents and students and stuff to help, but that's in an office setting, not for telehealth. So nothing mentioned students anywhere, or residents, and most of it is who could originally bill that service anyways. So if your nurse practitioner, your PA, and your MD are all credentialed with Medicare to bill those services to Medicare or Cigna or whoever, then that's who can bill those services. Residents, you typically can't bill their service, in most cases. So and I would still fall back to this is an MD service. I mean, some of them specifically said no clinicians, no med techs, no RNAs. This is provider services. So if the provider is doing telehealth, maybe the resident could be helping with another in-office type of thing, and that would still be helpful to relieve some patient load. So a state agency providing behavioral health services closed to the public. Okay, live hearing that a lot of places are closing. Providers are working from their homes and contact patients to conduct their sessions, which mean these services are not patient initiated. Now, behavioral health is different. Behavioral health has different codes for telehealth. Okay. So I think you're not going to fall under that patient initiated G2012 or virtual check-in, or that is virtual check-in, e-visit, because behavioral health can bill telehealth via other codes. So if the patients are contacted based on appointments scheduled prior to COVID, they're now working from their homes, and I know behavioral health is very different. I would check out that blog or look specifically for behavioral health, telehealth, COVID-19. That should bring up pertinent COVID-19 information regarding behavioral health. Behavioral health is kind of its own entity, different from the medical practices in the medical world. They have a lot of different rules, and we know that there's a lot of codes for behavioral health, and most of those are allowed via telemedicine right now. So I would definitely check with this particular carriers as to whether they can do them from home. I know my daughter, when she's away at college, she does her services via telehealth. She happens to be home right now, but now her provider is at home because of the office, because of COVID. So, there's ways that telehealth is being billed. Are the CMS telehealth guidelines going to be the same as the state Medicaid guidelines? No, because every state's different. So CMS is using this national guideline where your states are doing what they would normally do. So they may follow CMS, or they may have the state insurance agency coming up with something on their own. So if they don't want to follow what the national says and the state, because that's the different thing about Medicaid, they're half funded by the federal government. The other comes from your state. So they're partially funded one way, so they don't have to follow all these rules. They have to offer certain services as mandated by the federal government, but they can have their own rules as well. So in this case, a state agency is going to follow some of their own rules, not CMS. If Cigna allows virtual to bill face-to-face with the GQ, does that mean the reimbursement will be lower than an in-person face-to-face? Cigna did not mention that. They only need that GQ to identify as being a telehealth services, where CMS specifically said everything is going to be paid as if they were in the office. Cigna did not specify that, so I can't say what they're going to do with that GQ modifier, if they're going to pay less or not. Just remember, the thing about a patient coming into the office, though, is the part of the RVU that's established for those office visits. There's 3 components in an RVU. There's work, there's overhead, and there's malpractice insurance. So we don't have the overhead expense via telehealth. So they may pay a little bit less because we're missing one of those components, or you're not using as much for one of those components. We don't have the lights on and the electricity and the space that's being used at that time. Somebody else is now using that space for an office visit who can come into the office or needs to come into the office. So I can't answer that for sure. It would be up to each insurance carrier. They did not specify that on their website, that they would be paying less for telehealth services. So I'm not entirely sure. And, you know, I know doctors are going crazy right now trying to see everybody that they possibly can, but hopefully they're not worried about what they're getting paid. Hopefully they're worried about the care of their patients, and that's my personal hope. That's my opinion. I did not pull up the Blue Cross Blue Shield Federal Employee Plan. I apologize. I know that that is a big plan and that is a nationwide plan. I actually got carried away looking up some of the other insurances, and I didn't look up Blue Cross Blue Shield Federal, but they should have information directly on their website as well for providers for COVID-19 telehealth. And simply Google that. I know Google's a easy thing to say all the time, but that's where it's one place where you can narrow down your information. You can go straight to, you know, FEP.org and see what they say, and just do their search for telehealth, and you should be able to find some information. I'm sorry, I didn't pull that one up. And as it was, I was thinking this is going to go way over with all my slides that I had. So, telehealth, you can still bill 99212 through 215, dependent upon the insurance carrier. Now, you're not specifically going to meet a 215 via telehealth. Remember those high-level plans. How can you reach a high level for when you don't have an exam? So you're going on history and medical decision making. It's kind of hard to reach a 215. So just keep that in mind. You may not reach those high level visits. You may be looking at 212 and 213s during this time. I know I saw it last week. I didn't run across it this week when I was researching information last week. There was a site somewhere that I saw that described the visits, and it specifically said you will not get to a 214 or 215. It was an insurance company that said that, and I just can't remember who. So I didn't run across it today. So transitional care management be provided via telehealth. I didn't look at all 4 pages of those codes specifically. So that would be something to look up under CMS, because some of the other carriers, we gave those codes for the other carriers. So if you're worried specifically about CMS, go look at their telehealth book that was just updated for March, and it was 4 pages of codes. So there's a lot of codes on there. I only grabbed a couple of them that I was going through, and I only did a snapshot of 1/2 of one of the pages. So it is possible that transitional care management is on there, but I can't say for sure. It would be listed in that brochure. They say the patient can be at home or any other setting, but they're denying for assisted living centers. I would possibly give their computers a chance to update too. So it is possible that whoever, if it's a local MAC carrier, perhaps they may not have updated their information. So like we said, that COVID code is not even going to be eligible to April 1st to be billed. So some of these telehealth, they may not have updated the computer systems yet. So I'd give it another try. And if it's listed as the assisted living center is listed as one of those places of services, then I would reach out to the MAC carrier and find out why it's not being paid. I know I can't just offer a bunch of information in your answer, but hopefully I can direct you to where we can find the information. Somebody said that, yes, annual wellness visits are approved for telemedicine, but the problem comes in with reporting the vitals. The patient would need to have a scale, a blood pressure, cough, etc. I know vitals is one of the components that is required. And if an annual wellness, now an annual wellness visit, the IPPE has to have everything on there. The annual wellness visit, I thought those were suggested. I don't know if maybe you've gotten a denial already saying that this wasn't met, but you could, I don't know if you know, that is a difficult one. And which is why I didn't, you know, and when I addressed this just a little bit ago, I don't know specifically about annual wellness visit. I know I saw it, but I didn't dive into it to see what they're saying for right now. But when I did a presentation about IPPE and annual wellness visits, I know IPPE, you have to do every one of those requirements because it's the initial welcome to Medicare. But the annual wellness visit, I thought those were suggested. Would be something for me to look into and follow up on, perhaps in a question in the forum or club. I would take a little bit more research. I love research though. I love finding the answers. How would you code a FaceTime visit between a patient and provider that lasts 14 minutes? Documentation states telemedicine, patient consent, and has elements of E&M if it's done in person. If you've met, it depends on the insurance carrier and what they're allowing for that FaceTime code. That's your G2012 or synchronous, depends if it's a commercial carrier and they were allowing one of those other codes for synchronous communications. Now you have your time thresholds as well. So remember, I know they say, you know, 15 minutes, but it's after 8 minutes, it's 8 to 15. So you have your time thresholds as well. So to bill for 15 minutes, you have to pass at least 8 minutes. So that's possible. That's the code to use. I'd have to look at a specific example of the insurance carrier, and I'm sorry, I'm an auditor too, so I kind of like to look at all the information and see if I would come up with that. Sometimes it's hard to say what would this code be without knowing some more information. And without, I didn't make myself a spreadsheet of all these codes and insurance carriers, so without knowing what that code is specifically. But if you're trying to bill based on time, then you had met that threshold if time is something that's allowed for the code and allowed for the carrier that you're going with. If we are in a primary care pediatric, do we use modifier QT or 95? Being that QT is institutional, and I know it's institutional, but some of those carriers required, oh no, not QT, GQ? Yeah. Is that it? I got them all going through my head right now. GO, GT, GQ, QT. Again, it was going to depend on the insurance carrier. Now, of course, a pediatric PCP, you may not be billing Medicare. So it would depend on what the carrier was allowing. And most of those carriers specifically spelled out what modifiers they wanted to use, because that's how they're going to denote that this was a telehealth visit and not an in-office visit. Oh. Okay, let me go back, and I hit a button, so I might have skipped some here in between, and I apologize because I hit the wrong button. Places. Let's see here. All right. Well, yeah. Now I know this is, and I know I gave a lot of information and you guys are asking a lot of information. Looking at a lot of these questions are coming in like right before I finished. So I assumed I would have covered that information, or perhaps it just skipped over. Let me see if I can pick one or two more of these. So if we did a phone-only evaluation and management allowed without video during this time for Medicare, yes, that is their G2012 code that they were allowing. It's not necessarily an evaluation and management. You're, doing an assessment with the patient, reviewing their information, reviewing their symptoms, noting their condition and your medical decision-making process. That's the only one that they're allowing for the phone. So you're not doing a 99212 over the phone. We can't do that. That has to be video synchronous. Let's see here. Will this session be done again? I'll be happy to do it again. What about nutrition services? Those specific codes, I'd look at Medicare. Now, no other insurance carrier specifically said nutrition services. They were doing, they might have, some of them said whatever code you would bill in a normal office situation. CMS has that 4 pages of codes that are allowed to be billed during telehealth, and nutrition services, I did not, just like the transitional care, I'm not sure specifically if that's on there, but a nutritional professional was listed as one of the providers who can provide telehealth during this time. So just trying to go by deduction, if that's one of the providers, then there should be a code going along with that as well, a typical code. I love all these questions. This is so great, and I certainly hope that I provided enough information for you guys. Try and check out some of these links here, a specific carrier that you use all the time. Check into them. Again, let your patients know if your office is set up for telehealth so that they can, reach out for these services. I'm sure they're concerned about their own health and their upcoming visits and what's going to happen. So if we let them know that there's options available, you're going to help put them at ease and help make them feel more comfortable at this time as well. Let them know it's available, but there may be expense included. So just, be sure to answer their questions. If you don't know the answer, let them know you'll look into it for them. You'll get back to them, dig into it a little bit, do some research. I love research. I love finding these answers. If you have a specific question, a specific scenario, put it on the forum and see if we can help you with that. See if we can come up and find the answer for you. So I hope this has been good, and I'm sorry I can't get to all the questions. I feel bad, but I'm glad that you guys have a lot of questions about it. Again, we will do the best we can to answer what we can for you. So I hope you guys had a good evening, and we can bring up COVID again in the future because it is a hot topic right now. So I hope everybody has a good night. See ya.